With this said, I go back to Richard, and so whom you don't transplant, like, whom do you resect rather than transplant?
Well, in general, resection is always the preferred treatment if someone can be resected, meaning they don't have contraindications to resection. The value of a transplanted organ obviously should be saved, I think, as a last resort, and I think that's the general acceptance in the field. So given that these patients have underlying liver disease and a malignancy, who are the ideal patients? So I think what limits most patients is probably their liver physiology. Obviously, patients need to be well compensated. Child-Pugh A, working with Ron Busuttil at our center, we use a platelet cutoff to measure portal hypertension. That is to say, someone with a platelet count less than 100,000 will not be a good candidate for resection. Other comorbidities. And I think, as it turns out, practicing in the United States, a lot of the patients that we see have hepatitis C, and unfortunately, by the time they develop liver cancer, many of them do have, less compensated cirrhosis, in which case transplant is a better option, as compared to hepatitis B patients where they have better liver function at the time they come to presentation.
Sure, sure. Laura, however, here I would say that if we have any transplant surgeon, they don't necessarily agree totally with Richard. So I think the debate is still on, because some people will argue that transplant will be a first indication as well. So your thoughts
I think you can debate it both ways. So
both ways.
To be listed for a transplant for liver cancer, it's supposed to be unresectable disease, and that may be different based on what surgeon you see. Degree of portal hypertension is very important, and if you have a corrected sinusoidal pressure above a certain level, the magic number has been 10, and that's what Barcelona has preached, and I think most people in Europe and the United States use that as a cutoff, or surrogates such as a spleen greater than 12 centimeters, presence of varices in a large portal vein, or platelets less than 100,000 is a surrogate for increased portal pressures. But we're seeing with the Hong Kong criteria, and there have been some recent articles that challenge that even with increased portal pressures, as long as it is a minimal resection and you have a MELD score less than 10, that some of these people could be resected. And when you look at a Child-Pugh A patient, resection versus transplant, we're never going to have a randomized controlled trial, but when you try to look at Markov modeling, the difference in overall survival is not very much. It's been quoted to be about 7 months with transplant in terms of life gained. What you do gain is decrease in recurrence rates. So recurrence rates are much higher with resection as opposed to transplant, but most patients care about, well, how long am I going to live?
Very, very important, and as such, really, this debate will go on. But as we heard, so if I were to clarify that the transplant is really aimed at the sick liver, as kind of, we're just translating what Dr. Kulik said. And in addition to that, in other words, a sick liver means that you can't resect it, while the debate will continue to go on with the Child-Pugh A patients who really have a healthy liver but same time resectable. And the question is, transplant or not? This is kind of a continued debate. And as we heard, probably a certain randomized trial of that nature will never happen. So this is kind of like going to continue to evolve in the academic setting, and really it will depend on who you're talking to and what kind of opinion is being built around.